What's up, Dot?
What's up with you?
We're gonna get started. I know we did this 2 weeks ago, but Dr. Mucci was kind enough to be our advisor for the actual for real last time. And he actually saved our butts. So, round of applause for us.
Dr. Mucci!
We are going over cerebellum and brain, Basil, Ganglia tonight. Some of this stuff is pretty anatomy heavy, and I know that's so not fun and it's kind of the worst, but you need to know it. So, yeah. Okay.
Word.
Happy learning.
Grace.
Happy learning.
Hi, everybody.
Thanks, sister.
It's been so long, I feel like, since I taught. I know it's just been a quarter, but I just feel like you get a little rust on you. So if words are hard for me today, then bear with me, everybody. This is also the first time that we taught cerebellum in a while. I think that the last time, I was looking through old slides, that we actually taught a cerebellum PowerPoint was my first quarter, I think. So that was literally like, what, 6 years?
What?
That was, yeah, I think so. Maybe a little more.
I was the last one to teach cerebellum?
Yes. So we've in the past, we've like tacked cerebellum onto lobes of the brain, or we've had Dr. Esposito come to teach. So we haven't taught like a lecture with primary cerebellum, basal ganglia focus in a while. So cool. We have a lot to learn today, and a lot to get caught up on. Oh, I have to plug this thing in.
The little dangly thing.
That little dangler. Okay, so we're just going to review. Everyone should know these, right? They've been coming pretty consistently. Somebody raise their hand and name the 4 primary lobes of the brain. Anybody. It could be somebody. It could be an officer. I don't even care. Show off a little bit. Yes. What's a little hidden lobe in there? Insular, right? Okay. And then we're going to go on. We're just going to, okay. We have a lot to cover. So we named our lobes. And then we have what we're talking about today, our cerebellum. Tucked right back here. I kind of think that the cerebellum reminds me of like the little motor on a boat, right? That's what it looks like. I can never unsee it now. But it kind of goes hand in hand with its function because it has a huge critical role in motor function, right? In driving our system to work appropriately. So we're going to review the loop really fast. Okay, we already have them up here, so I'm not going to quiz you guys on it. But we're going to start with cerebellum. We're going to say it all together. So we start cerebellum. Meso, thalamo, cortico, ponto, cerebellum. Good. Okay. Now somebody tell me without looking.
Cerebellum, meso, thalamo, cortico, cerebellum.
Great. Okay. Now exciting news. This like random loop that you're like, I have no idea what that means. I'm just memorizing it, right? It's going to make a little bit of sense today because we actually have a pathway that information travels through our cerebellum, and it's actually called the cortico-pontocerebellar pathway. What are the odds of that, right? So we already know the direction that it travels. That makes our life a lot easier, right? All right. So a few little fun facts about the cerebellum. So it's Latin for little brain, which is ironic because even though it's only 10% of the brain's mass, it actually contains 50% of the total neurons. So it is a densely packed structure, right? And it's really important because it is our fact checker, essentially. It's our oscillation damper. It's making sure that all of our motor commands and all of our thoughts are in order and they essentially are error-free. So it's our, what's that tool that we use to edit papers? Autocorrect. Yeah, it's like our autocorrect system, right? And sometimes autocorrect can mess up, and it can say duck, right? And you didn't want it to say that. Our cerebellum can mess up sometimes. Our cerebellum can mess up sometimes too. And so essentially, we want a properly functioning cerebellum so we can get get our information, we can get our motor commands across as they should be. So obviously we can see how many more synapses are in the cerebellar neuron as compared to the average neuron in our nervous system. A lot, right? So there's a lot of information firing from the cerebellum. Oh, and this is something that's important to take into account. So as we're talking about information that comes in and out of the cerebellum, there's no direct motor output from the cerebellum, right? Now, I know that we didn't dive too heavy into lobes of the brain this quarter, but where does our motor output come from? What lobe of the brain? Say it with confidence. What is it? Frontal, right?
I didn't hear
So we have our motor cortex in our frontal lobe, right? And that's what's going to send out the motor command. Our cerebellum is essentially just our fact checker, and it's making sure that we're in the right spot, and it's saying, hey, if I want to send out this motor command, am I in the right position to where if I move my foot 10 inches forward, am I going to hit that next square? Okay, if my cerebellum is off and the fact checker is off, then I'm not going to be able to perform that correctly. All right. Oops, I gave that one away. Who wants to tell me who's taken the advanced exam? The ABCs of the cerebellum. These are essentially just big overview concepts that the cerebellum is responsible for. So, roles that it has. I know that some of you guys know this because you answered it correctly on your exam.
Justin knows it.
Yeah, very easy. Okay, well, we'll start with the one I gave it away, right? Accuracy. We want to be accurate in our movements. And how do we do this? We're taking into account visual information, vestibular information, and proprioceptive information. So what we see, so I see that you're this far away from me. I'm taking in visual information. My vestibular system is telling me where I am in space, right? And how I'm moving in regards to space. And my proprioceptive information is telling me where my joints are in space, right? So all of that is important in having accurate movement. Balance. So balance is for B, right? Balance. To have appropriate balance, we need appropriate timing and synergy of muscle groups, right? So you know, who's in an upper quarters in muscle gait right now, or muscle gait, has muscle gait? Okay, a few of you, okay. So in muscle gait, I think right now we're talking about like synergistic muscle groups, right? So you have your antagonist and you have your, what's the opposite of an antagonist? Agonist, right? So we have certain muscles that work in opposition to each other to make sure that we can stand upright. And if your antagonist and your agonist are firing at the same time, then what's going to happen? It's not going to be a fluid movement. You're probably going to be rigid, you're going to be spastic, right? And you're going to be hypertonic, you're going to be firing way too high, and you're not going to have a very fluid movement. You're not going to be a very good dancer, that's for sure. Okay, and then our C is for coordination and cognition. And for a very long time, the cerebellum was only thought to have a role in motor. But now we know that coordination is not just for motor, but it's actually coordination of thought as well. So that's where cognition comes into play. So it's really, really important in learning new skills, learning new motor skills, and fine-tuning what we know. And that's why we say in neuro, perfect practice makes perfect, right? Because you could do something wrong a million times if that's not doing anything for you. So it's important in learning new motor skills to have that cognitive aspect as well, and knowing that you're doing it correctly, so it's effective. Okay, let's talk a little bit of anatomy. I know anatomy isn't the most enticing, but guess what? It now is. It's not going to be your favorite today because it's really, really important in understanding the difference between anatomical lobes of cerebellum and functional lobes of cerebellum. So here is a slice of the cerebellum, a mid-sagittal slice. So you have basically took the brain and you just cut it in half, right? And then this is it like unrolled. So if you took this like it was a croissant and you just like unrolled it like that, that's what it would look like. So we have our anterior lobe, our posterior lobe, which is the largest, and then we have our flocculonodular lobe right here. So our floccular nodular lobe, this is going to be our oldest lobe, right? So our oldest lobe, our most phylogenetically origin, whatever, comes from the most phylogenetically old origin, is going to be associated with our vestibular system. So this is going to be really important in integrating where we are in space and allowing that to be important information in determining how we move. We also have our midline here, and this is called our vermis. And does anybody know what vermis actually means in Latin, or where it comes from? Worm, yeah, and it kind of looks like a little worm here. And it's not labeled next to it, but this area right here, if I were to draw a line there and here, that's going to be our paravermal zone. And it's also called our intermediate zone. So this is going to be really important when we talk about our deep cerebellar nuclei and the role that they play and where they fall on in these lines. And then we have our lateral hemispheres. All right. Now this is where it gets a little different, right? So this is like similar to the picture we just saw here, except it's shaded differently. This one makes it nice and easy because this one just stays the same. What was this lobe here? Flocculonodular lobe. And functionally, we call it the vestibulocerebellum. It's pretty easy, right? Because what did I just remind you guys? That our flocculonodular lobe has close ties to the vestibular system, right? So it's taking in all the vestibular information from vestibular nuclei, and it's outputting it to those vestibular nuclei as well. However, this is where it gets a little different. So remember how I said that we had that vermis here, and then we had paravermal areas? So that's going to be our spinocerebellum. Our spinocerebellum is what takes in information from our spine and our muscle spindles. Okay, so it's going to say, hey, according to my muscle spindles, I am in this XYZ plane in space, right? It's going to allow you to know where your elbow is, where your wrist is. It's going to take in all the information from our muscle spindles. And it's easy to remember just because it's spinocerebellum. This is like midline, as that's the meaning of, right? So it's going to make sense in terms of terminology. And then we have our cerebrocerebellum, which is our lateral hemispheres. And can anybody guess where information comes in from our cerebrocerebellum, or for our cerebrocerebellum? Cerebrum, right? What is the cerebrum? Yeah, it's just our brain. It's our outer brain. So, as I was saying before, we get a motor command sent to our cerebellum. Our cerebellum is not putting direct motor output right into our body. Where in our cerebrum is our cerebellum getting information from? From the cortex, but where in the cortex? What lobe? Frontal lobe, right? It's also going to get information from our parietal lobe. Who knows what our parietal lobe is responsible for?
Mapping.
Yeah, sensory mapping our body, where we are in space. So your cerebellum here, your cerebrocerebellum, is going to get information from the parietal lobe and the motor cortex, so your somatosensory cortex and your motor cortex, to say, hey, here's the motor plan and here's where I am in space, so figure out what to do with it, right? Make sure that it's correct. All right, so these are all of the areas that are important for the inputs of the cerebellum, and we'll kind of talk about the pathways in a minute. But now we're going to talk about our cerebellar outputs. So these are our deep cerebellar nuclei. Some of you guys may have heard of deep cerebellar nuclei before. We use the mnemonic, fat guys eat donuts. So who wants to take a shot at medial to laterally? This is medial to lateral. What these nuclei are named. Let's start with F. Fastigious, fastigial nucleus. Okay, what about G? Lobos. E? Emboliform. And D? Dentate. Okay, so we have our fastigial in pink, right? And what's this area right here? Yep, it's spinocerebellum functionally, but like anatomically it's the vermis. So we have our vestigial right in that vermal area. We have our globose, also in the vermal area. We have our emboliform in the vermal area, kind of touching the paravermal area. And then we have our dentate, which are in that paravermal area, but also reaching the lateral hemispheres. So, as I said, these are cerebellar outputs, right? So that means these are where information is going to leave the cerebellum, and it's going to go to different parts of the body. So each of them have a connection. Oh, before I go on, interposed nuclei. Which one are the two interposed nuclei? Somebody say it with confidence.
Vestigial globus.
It's going to be globus and emboliform. So it's the two right in the middle, right there. Okay? So those are basically the interposed nuclei are connected to our red nucleus, which are responsible for flexing our proximal muscles. So the way we're going to remember this, F is going to have output to the face, right? We're just going to think face as in midline. That means face, but I mean midline, the entire body, right? And we're going to go out a little bit further. Our globose are going to send projections out to glenohumeral, right? Glenohumeral joints, so we get a little bit further out from the face. E, we're going to think elbow, so right to the level of the elbow. And then D, we're going to think of digits, right? So that's how it keeps it in line of remembering where the outputs go to the body.
What does interpose mean?
Interpose, so these together are going to have, I don't know exactly what the word itself, but
It limits-
essentially interpose, it means that they work together to flex the proximal muscles. So they send their projections to the red nucleus, which is responsible for flexor tone, yeah.
Interposed, they're just like in between.
Okay.
Yeah.
Oh, okay, yeah. Well, then that makes it easy. Interposed, the two that are right in between, the sandwich ones. Okay, how do we feel about this so far? We know this is a lot of anatomy, but it's important, right? We feeling good so far? Okay. All right, now we're going to talk about inputs to the cerebellum. So, we mentioned this, right? Cortico-pontocerebellar tract. What part of the cerebellum, what functional part of the cerebellum is receiving inputs from the cortex, or the cerebrum? You want to go back? Out of spinocerebellum, cerebrocerebellum, and vestibulocerebellum, which functional portion is taking in inputs from the cerebrum? Cerebrocerebellum, exactly, right? So our cortico-pontocerebellar tract is taking information from the cortex, sending it to the pons, and then it's going to the cerebellum. How easy is that, right? Cortico, cortex, ponto, pons, cerebellum. Oh, how easy is that, right? Okay, that's going to be a nice and easy one for you. Spinocerebellar tract is taking in information from our muscle spindles. What functional lobe is integrating this information? Spinocerebellum. Easy as that, guys. There's a tract associated with the functional name, right? And then we also have vestibular afferents coming in. And these actually aren't going to interact with our deep cerebellar nuclei. They're going to have their own system where they essentially, the vestibular nuclei are going to tap into the flocculonodular lobe, and then we're just going to send output directly. So that one, vestibular afferents are not tied to deep cerebellar nuclei. Okay. Let me get a sip of water. How are we feeling with that? Good? Okay. Well, we're done with all the heavy anatomy stuff, so we can actually have a little bit of fun now. Okay. Now we want to understand how the cerebellum called our feed forward, efferent copy, feedback loop, called ready, set, go. Okay? So we're going to start with ready. This is our motor planning system. So I'm going to walk you through step by step, and then I'm going to use an analogy, right, to help kind of set this in stone. So I like to box. So I'm going to use the analogy of throwing a punch, right? Okay, so if I'm right here, and I want to punch McKellar in the head, sometimes I do. No offense. Okay, so if I want to throw a punch and I want to hit McKellar in the head, first my cortex has to say, hey, I'm going to come up with a plan that you punch McKellar in the head. Okay, so your cortex is coming up with a plan first and saying, we're going to make this happen. So the cerebellum is going to tell the cortex, my cerebellum is going to say, hey cortex, Mr. CEO, boss man, this is exactly where I am in space. So if you want to punch McKellar in the head, it looks like you're in a good distance to be able to do so, right? Based on my calculations, based on the proprioceptive input that I'm taking in, the visual input that I'm taking in, based on all the information that I'm processing right now, it looks like you're in a good space to do so. And it's going to tell you, okay, that sounds like a good plan. So I'm going to show you here. Well, yeah. All right, so this is going to be how it looks. So, oops, I don't know the order of what's going to be. So the cortex, right, sends the plan down to the cerebellum. And it says, hey, I want to punch McKellar in the head. Cerebellum says, hey, I'm talking back to you, Mr. Cortex CEO man. Looks like you're in a good space to do so because I know exactly where my body is in space. All right. We got that part. That's the feed forward. That's the motor planning system. Then we have our efferent copy. This is to make sure that we're set in stone. It's to make sure that our system is in an appropriate position to do so and make sure that the plan is edited to a T. So the cortex is going to send one copy of the motor plan. Mr. CEO man is going to send a copy to the cerebellum and say, hey, fact checker man, cerebellum, here's the plan. I'm also going to send a plan down to my ventral horn cells who are responsible for motor, for performing the action, right? So the ventral horn cells are going to be in our spinal cord and those what send projections out to our skeletal muscles. Okay, so the cortex is saying, hey, I'm sending a plan down, cerebellum. Here's a copy for you, and here's a copy for the ventral horn cells. Make sure that it's the same plan. Cerebellum, this is your only job. Make sure that I sent you the same plan that I sent the ventral horn cells. So the spinal cord, or our ventral horn cells, is then going to fact check with the cerebellum and say, hey cerebellum, fact checker, this is the plan I got from the box. I'm just making sure that this is the plan that you want me to do, right? So going back to the analogy, I'm here. I want to punch McKellar, right? My cerebellum just got a plan from the cortex, right? And it says, okay, it looks like this is the plan. This is the set in stone plan. All right, I'm going to send a plan down to the ventral horn cells. Ventral horn cell sends it back up to the cerebellum and it says, looks like you're all set. That looks like the plan is the same. You're in check. You're good to go, right? Okay. Based on prior experiences, this is where it comes from. So it's saying, I've stood this far away from somebody before, and based on my experiences standing this far away from somebody, if I were to extend my arm, I know how long my arm is, and I think that I'd be able to reach it. I think I'm good. So that's fine-tuning the plan. And then lastly, we have our feedback mechanism. So this is when our motor command is finally sent to the ventral horn cells. So this was the plan. It's just sending out the blueprint. Now it's the command. It's saying, okay, time to send the command out. Fire away. Let's throw the punch, right? So I throw a punch. That's the feedback. And the receptors from my hand that go here and hit his ear are going, wait a second, that's not his head. I wanted to hit him right in the jaw, right? So it's saying, oh, correct yourself. But your cerebellum has the ability to, as you're throwing the punch, correct itself mid-movement, right? So if I'm here and Michele starts to dodge, right? And I realize that he's dodging, then I'm able to fine-tune my plan to potentially follow his face, right? So if our cerebellum, sorry about using you as an example, you're a good sport for that. Yeah, okay, all right. So we can talk this whole system through. Okay, so your cerebellum is going to make any changes it needs to during the motion to fine-tune it. So what do you think is happening if the cerebellum isn't functioning properly in one of these areas? You're probably going to be completely dysmetric, right? You're going to be completely thrown off. You're not going to be even close to accurate, or you're going to be constantly trying to redirect. You can't figure out exactly how to do it in one fluid movement. The whole point of the cerebellum is fluidity, right? We want to error correct and make sure that this is all one fluid movement of throwing a punch one time, not That's not a punch, right? Okay. So that's that. We're going to do a little breakout now. Just real quick, I want you guys to come up with an example on your own. All right, do something unique, not throwing a punch, maybe like grabbing a cup or brushing your teeth or something that you're really uncoordinated at. You can use an example for that and figure out what's going on, right? And walk through with your friends, walk through with your partner, and talk about what's happening in each step. So just real fast, break out with somebody, come up with an example. If you need help, we can walk around too. But does that kind of make sense to you guys? The feed forward, current copy feedback? Okay, great.
Just talking through it.
Yep, just talk through any example with your partner.
This is the first time I'm using my typewriter. Good thing is, okay, sugar? No.
actually had from a class. Actually, you should take it away.
Yeah, exactly. Cool. So the class that I was talking about is called neuromechanics. It's taught by Dr. Downs, who did a lot of work in developing the global mechanical assessment. That's like the sports chiropractic adjusting thing. So in that class, we mostly look at a lot of just like research articles that's out there for the concept of neuromechanics, which, as you guys can guess, is like how the nervous system works and how it moves, like that interplay together, which is kind of right there on the board for us. So this article in particular, I'm just going to read to you what they have put into it. So it says, well, let me backtrack. They're looking at feed-forward mechanisms. They also call them anticipatory postural adaptations. They're just kind of AKAs in their world. And what they're seeing is there's a delay between when this pathway gets activated and when we actually execute the plan. And they say, these are their words, the exact mechanism is poorly understood, but the loss of anticipatory control of the proximal segment / spine during limb movement, changing the center of mass, may adversely affect articular stability. The other thing they say is there has been little work to date considering the implications for clinical practice of altered feed-forward mechanisms in patients with dysfunction. So to translate that, what they're saying is we are aware of the fact that there is a delay between when the nervous system is activating and when the muscle is moving. So they agree that there is some kind of neurological delay in this feed-forward plan. So why does that even matter, you may be wondering? Because they're wondering, well, they can't figure out why it exists. They acknowledge the fact that there is a delay, but they don't know why. Your why is up on the board. Your why is what we do in this club. The science behind the art. Your functional neurology, your chiropractic. That is why there's delays. So this whole thing, I know it's a lot of very heavy neuroanatomy, but there's already research that exists that shows what we do works. It is merely the answer to why what we do works. Cool. Thank you. If you want the article, I have it. Yeah, here.
It's highlighted in 87.
Yeah, guys, isn't that so exciting though?
Oh.
Like, go ahead.
Sick, by the way. So it's been around for a long time.
But we are able to understand constructs that literature hasn't even yet covered yet. Do you guys even grasp that? Because I still even sometimes I'm like, I know nothing. We know a lot. We know a lot, right? So the more that you understand the neuroanatomy, the more that you understand the pathways, and the more you understand things like cerebellum loops, right? And you can grasp that concept and you can walk through any example. And a patient comes in, and I was just using an example I used to have, every once in a while I'll come back up, but I'll go eat something, especially soup, and I'll intention tremor close to my face, right? But it's only when I get close to my face. Your patient is never able to eat soup, right? Okay, well you know the cerebellar loop and you might be able to figure out where the problem is and be able to correct it. All right. Anybody wants to take a picture of that? For you? It's kind of nice just as a visual. Okay, you want to walk through it one more time? Cortex says, hey cerebellum, I'm thinking about eating this soup. Cerebellum's like, oh yeah, okay, well your hand's holding the spoon, it looks like exactly good coordinates, blah, blah, blah. Looks good, Cortex. Okay, Cortex is like, all right, I'll send the motor plan out. Here's one for you, cerebellum, and here's one for you, ventral horn cells. Ventral horn cells are like, hey cerebellum, fact checker man, just making sure we're good, we're in check, right? So this basically just covers the feed-forward and efferent copies. Good? Okay. All right, so now we're just going to do some cerebellar tests, right? So how do we test the cerebellum on somebody? First, yeah, you don't want to punch them actually. First, we're just going to look at gait, right? We're going to see what they look like walking, normal, right? So somebody with a cerebellar lesion or dysfunction, now, how might they present walking? If they're unstable, right, and they don't have great coordination of their limbs, they're probably going to have a wide-based stance, or a wide-based gait, right? So they're going to walk like this. Because they put their feet together, then they're off balance, right? Okay, so you're going to see usually a wide-based stance. Then when they try to do tandem stance, which is essentially what they make you do if you've been drinking too much and you get out of the car and right? Please pull you over. They're gonna really, really struggle with this, right? And they're gonna fall to one side, fall to the other, right? So this is why cerebellum is the first thing that's affected when we drink alcohol. A lot of these symptoms, a lot of these tests are things that you can test on your friends when you guys are drinking, and you can be like, whoa, fact check, your cerebellum is not working well. Boom. Roasted. Okay. They're also going to have a postural tremor. So who was at the CARE seminar? Okay, we tested this at the CARE seminar. What is a postural tremor? Yep. Or out. Yeah, right? So you might see shakiness in one side, you might see shakiness in another. Or you might see them raising, right? Because essentially somebody with cerebellar dysfunction might have hypotonia, right? And they might start recruiting muscles. They might not be able to hold there, right? Or they might have a lack of coordinated movement, and they might have a little bit of a tremor. So these things here are all going to be more truncal ataxias. So do you guys remember looking at the diagram, and we have the vermis and the paravermal area, right? Okay, so if there's a lesion there, those are going to be more truncal lesions. So problems with the trunk of the body. These are going to be more appendicular and digits. So dinocokinesia is going to be rapid alternating movements. So you can do it like this. You can have a patient flip their hands, rapidly alternate, pronate, supinate, right? Or you can do it like this, have them do this. You can do one hand at a time, and then do both at the same time, right?
What are you looking for?
So for DDK, dysdinocokinesia, you're going to look for one side to be either floppier than the other. So if now is cerebellum ipsilateral or contralateral? Ipsilateral. Okay, so if I was like this, then what side cerebellum might you be concerned about? Left, right. Okay, so you might look for like uncoordinated. They might not be like fully pronating, supinating, right? One side might be slower than the other. All right, and then we have finger to nose. So you want to come up here and be my patient? Okay, so for finger to nose, I'm going to have Michele start by touching his nose. Go ahead and reach your finger all the way out. So I'm going to see how far his finger can go, because I don't want to be like over like, try to reach this, Michele, right? Nobody's going to be able to do that. So I see here. Okay, so back to your nose. Okay, then I'm going to go here. I'm going to say follow, go back to your nose. Touch here, back to your nose. Touch here, back to your nose. Touch here, back to your nose. You can switch hands, and you want to make sure you're doing it in all the quadrants, right? So somebody with dysmetria might experience, can you model somebody with dysmetria? Okay. Here. See how he'll either overshoot or he might undershoot it and then have to refract it back? Yeah, okay. So you guys kind of point there? Okay. Heel to shin. We're going to test their lower toe. Yeah, you can go. Okay. So for this test, I just want you to bring this heel up here and drag it on your shin. And then the other side. Okay, looks pretty easy, right, for us. But for people with cerebellar lesions, might have a really hard time. I actually have a video in a minute, and I'll show you a few of the presentations. Piano fingers, same thing. This is just testing more like digits, right, which is what deep cerebellar nuclei? Dentate. I heard it. Okay, so you're going to do piano fingers both sides and see which one is maybe slower, less coordinated. Maybe they're just going down like this or like really rigid, right? And then this one I like to do. This is like a rebound. So rebound test is time. I'm going to have you actually stand up. Okay, so as we know, cerebellum is our correction system, right? So I'm going to have you put your arms out in front of you like this. Okay, I'm going to have you close your eyes. I'm going to bounce one of these down, and I want you to bring it back up to the same level as it was before. Okay. Okay, can you test this side? All right, so what you're going to look for is if you might bounce it up. Hold just a little bit stronger. Hold a little bit stronger. Let me see. if they come back up, they might oscillate, right? So they're like, I don't know exactly where it was in space, correction. Okay, now here I am. All right. And then speech text. Okay, so something else that when you're drinking and you're out with your friends, what are you going to do? You're going to slur your words, right? So that's something that you might see in somebody with a cerebellar dysfunction. They're not drunk, they're just slurring their words constantly, right? But you also might see scanning speech. So scanning speech is I'm going to have you say pop, 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 pop.
Pop, 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 pop.
Ka, 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 ka.
You know what it means when you call you?
La, 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 la. Okay, and then can I have you say pataka, 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 pataka? Good. Okay, so somebody who has scanning speech, they're gonna break these down into the syllables like really intensely. So it's gonna be like pat ta ka, pat ta ka, pat ta ka. Okay? Or they're gonna slur. So same thing with these ones. You can say pa 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 pa. You can go fast and fluid with it, right? They might say pa 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 pa. They have to break it down. So you can even have them say like a more difficult, lengthy word, like say Declaration of Independence. It's gonna sound the same way, right? They're gonna break it down into choppy words. All right. So this is just a little mnemonic to remember ways that somebody with cerebellar dysfunction might present. Danish, right? So we have dysdiadochokinesia, which is our rapid alternating movement, and dysmetria, which is what test? Yep, finger to nose. Okay, we have ataxia, which is essentially just an uncoordinated gait. It's a lack of ataxia, just means lack of order. So you're going to have an abnormal gait. What is their gait going to look like? Wide base stance. You might also have decreased arm swing. That's not wrong. It's also highly connected to our vestibular system. That's why we might have nystagmus. We might have difficulty tracking eye movements, right? These all tie in. We're going to talk a little bit more about that eye movement this week. I for intention tremor. So when I go out to reach for something, and then right when I get towards the end of it, that's when I start to tremor. Slurred scanning speech, and then hypotonia. Hypotonia kind of goes into the speech as well, but also with reflexes. If I were to test Michele's patellar reflex, and his leg were to sustain, what's it called? Somebody help me out here. No. I'll look it up in a minute. But instead of just reflexing one time out, if it keeps swinging,
Contraction. Clonus.
is that?
Clonus.
I'm thinking pendular. Pendular. Yes.
Sure not.
Pendular reflex. Okay, so it's going to basically just look like a pendulum. Kind of like similar to how this is going to be like a pendulum as well. Same thing with you can do a reflex. And if this side, it just goes boop. And this side, it goes boop, 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 boop. Okay, well, cerebellum, right side, right? Okay. Do you guys want to watch this real fast? Or you want to do the breakout practice on each other? You want to watch this?
Yeah.
Yep.
All right, so you guys can shout it out, but tell me what you guys notice with his gait. This is normal gait. So what are our findings so far?
Right arm is swinging slow. That left arm is swinging. Right arm, or the right foot is
Something that we talk about with Tanner gait too is like it's really important. The foot behind is the most important one that we're looking at. All right. You see that? See his gait? Good. All right. Good. Now something that I've been finding too with is that I can turn this up?
Yeah, it's on the little square.
Little screen,
Little square.
little touchpad square right in front of you.
Master volume.
It's fine. Something that I've been finding, there's actually different kinds of cerebellar ataxia. So I think this one was cerebellar ataxia type 1, and then the next video I'll show you was type 2 and type 10. I haven't looked enough into them to differentiate, but just so you guys know, there are different findings according to the type of ataxia that somebody has. Did we see the hands? No. Yeah, it's okay. Yeah. How was it so loud before?
Because it's your It could be really loud.
I got tested because I knew I ran to point back at.
Can you say pop, 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 pop?
Pop, 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 pop.
Okay. Can you say ka, 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 ka?
Ka, 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 ka.
Can you say la, 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 la?
La, 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 la.
Okay, how about this? Pataka, 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 pataka. Keep saying it as fast as you can.
Pataka, 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 pataka.
Okay.
So just practice. You know this task. I'm gonna hold my finger out, ask you to point to it, and move it as you say.
Try to keep it as close as you can.
So not too bad, honestly, like, compared to the next video that you'll see, his finger to nose wasn't too bad. His heel to shin wasn't too bad. The primary thing there was more of the dysarthria, right? So with his pataka, 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 and his wide base gait stance. This one here is going to be a little bit different findings. Let's get through what it says. Okay, so it talks on. Eye movements are a little bit slow. Can one of you brainiacs also give me insight on this? I was trying to figure out what you would essentially consider this.
Yep.
See his finger movements?
Yeah.
What is that?
I would say he's just spastic.
Okay. I don't know if there's any area.
He's hypertonic, so he just like.
See, he struggles a lot more with finger to nose.
Moving stationary.
Mm-hmm. This is another thing too, so right, this is a frontal lobe test, but frontal lobe feeds into the cerebellum, right? So if you saw it worse on this side, I think hopefully we all saw that it was worse on the left side, right? What side cerebellum? What side cortex? That's good. Amazing, you guys are so smart.
What is that?
I don't know, I honestly don't know that test. I don't know if he's asked us.
Yeah, I think he's just tapping his heel.
It's probably like when you know when they do the padding
Foot
test
tap.
on your thigh, you can
Oh,
move
foot
your
tap. Okay.
Could be wrong, but that's my best guess.
See, this one he struggled a lot more than the last patient with heel to shin.
So does that indicate that the right side cortex was more of a problem than the left cerebellum because it was right associated?
Say that again?
So I'm saying like he had bad left, what is this? Finger tapping, and then bad right shin to heel thing.
I would say honestly, I'm gonna give you a total Dr. Ellis answer, and it depends. Like it really, I think that honestly you'd have to do further motor or like cortex tests, frontal frontal lobe test to determine who is actually a frontal lobe problem. I think though that since he's positive on so many cerebellar findings, like cerebellum would be probably, I mean, I don't know how we would rank on cortex. Yeah.
Oh, I have a separate question.
But I would assume, I mean, it is a cerebellar case. Do you guys have any other input on that?
Do you think it's just such a big cerebellar lesion that there's leakage over to the right cerebellum?
I think
Oh,
this is a basal ganglia issue. Like cerebellum's playing a role, but like
Because cerebellum
this
has.
is like he's got issues. So like you can say it's cerebellum. Obviously he has discoordinated movement.
They're
but
both fine.
he has a gajillion things going on.
And Kayla's gonna talk, I'm handing the mic over to in a minute. Kayla will talk too about, like, obviously cerebellum and basal ganglia, we're teaching them together for a reason. They're super interconnected. Their findings are gonna be similar in a lot of ways, but there are gonna be certain differences that you might see in somebody has basal ganglionic lesions versus somebody who has cerebellar dysfunction, right, or cerebellar lesions. So, do you guys want to break out really fast and try a few tests on each other? And then Kayla's going to take over? Yeah.
So I noticed in the second video that it was talking about spinal cerebellar ataxia, and I know that like in all I think there's like 40 plus types. That I do know is like a neurodegenerative type disees, so it's like Purkinje cell pathology within the cerebellum. So you're having like mass like cell death, so that might be like the leakage or like the
Yeah, we think it's probably Parkinsonian.
Yeah. I was also wondering, like, is there like a clear difference between just like, because in the first video it was like cerebellar ataxia versus like spinal cerebellar, because like this one is like hereditary degenerative versus like if it was like a traumatic injury like kind of thing.
Yes. Well, here's the thing. Like,
I'm sorry, that was a lot.
No, it's okay. Those are good questions. I think that the more specific that you can get based on the functional area, the deep cerebellar nuclei that are involved, which is going to basically help you determine what type of ataxia it is. You can have acute adult ataxia, you can have chronic adult ataxia, you can have acute or chronic child ataxia as well, right? And they're all onset from different things. Multiple sclerosis is a big thing. You're going to find ataxic patients and cerebellar dysfunction as well. So it really just depends. I mean, a neurodegenerative is obviously going to have probably a more widespread effect on the cerebellum. So probably that's why you're seeing it affecting both sides. Neurodegeneration makes me think too why it would be heavily considered a basal ganglionic case. And Kayla will probably, are you talking about your Parkinson's patient?
You can. I'd love to.
Awesome. Okay. Yeah, that was a great question. So that's why it's important to understand the anatomy and the pathways and the nuclei, right? Because they're all going to present different ways based on where the patient is ataxic. Do they have truncal ataxia or do they have appendicular ataxia? Is it more in their digits? Is it more in their proximal limbs, right? So where are they not able to fire correctly? So those are things that you want to start to pay attention to and recognize, okay, I'm not just treating somebody's cerebellar problem, I'm treating their truncal ataxia. Or I'm treating the fact that like they have a really hard time firing their bicep, right? Or firing their triceps. Their proximal muscles are all out of whack and they're firing at the same time. All right, let's do a quick breakout and just do a few of these tests. Choose a few to do on your friends and see if you guys have any findings. And then Kayla is going to take it from here.
Okay, so next we're going to talk about the midbrain, and if you're a midbrain meso, same thing. Those are the same thing. But a little more anatomy for you. I know we're going to throw it back to embryo, which after Lamero, I wish I paid just like a smidge more attention to embryo because it comes back every same time. But your midbrain connects your forebrain to your hindbrain. You guys don't really have to know that. You can know what's in it, but you don't have to know those words. Not particularly, unless you talk to Alex. Then he'll be like, what's in your T-encephalon? But you will know because it's right here. So your forebrain is everything essentially above and before your midbrain, or technically after if you're going through the loop. But anatomically, if you're looking at it, I don't want to be in that picture.
Don't worry.
But this is what's within it, and then in your hindbrain is your pons, your cerebellum, and your So it's because you haven't reached sleep paralysis yet. So your midbrain is still on, saying, "Oh, I don't want to be asleep yet. I'm gonna jerk. Like I'm gonna wake myself up because I'm not supposed to be sleeping." Your body is not doing what your brain should do. Or like, yes.
Does that have to do with like when you're falling asleep, you roll off of a cliff? Or does that not happen for anybody else?
Like you feel like you're
Like,
falling.
are you? You're
I'm walking
dreaming?
down a staircase
And then you
I
just boom. You're
Like,
wide
are you
awake.
talking about like your dream?
Yes.
If you're dreaming, you're not in sleep paralysis. So sleep paralysis is like you are in deep REM, no thoughts, head empty. I think.
Except for your dream.
But if you're dreaming, you haven't yet reached REM or deep sleep. When you reach deep sleep, you're in sleep paralysis, and your body quite literally is paralyzed, or it should be. Like people that move around a lot, they could have what we call midbrain windup, which is why they either wake up a lot, or they move a lot, or they like jerk in their sleep. Bunch of different things. If you move a lot, don't automatically assume you have midbrain windup. You could just move a lot. And then pain modulation. And pain modulation is through the ag or periaqueductal matter. And then important nuclei and things within your midbrain. You have your superior and inferior colliculi. Does anyone know what these are? Or want to take a guess? Then 3.
Wait, what?
Does anyone know what's a superior and inferior colliculi?
We just talked about it.
Visual and sound. So which one's superior?
Superior is visual, inferior is sound.
Yes. So your
Otherwise
superior
known
is.
as corporal collision.
Say that one more time.
Otherwise known as corporal collision.
I don't know what you're saying, but sounds cool.
Otherwise, it's called paraplegia. Is what you said.
No, corpora quadrigemina.
Oh.
Yeah, what he said.
This is fancy.
Yeah. I was gonna say that. Anyway, your superior colliculi is light. So it allows your eyes and your head to move and react to light. So everything has light, essentially, or a wavelength of light. And then your inferior colliculi reacts to sound. So what's really cool, and I didn't know this, is your superior colliculi has maps of everything. Has maps of everything around you so that you can be aware of everything and respond appropriately. Your inferior colliculi, when you close your eyes, I can tell you where everyone is, but not because my inferior colliculus has maps. It relies on the maps that your superior colliculus has. So your inferior colliculus, if you take the diplomate, apparently it's a question, does your inferior colliculus have maps? No. It relies only on your maps that your superior colliculus has already formed. And then cranial nerves 3 and 4 in your midbrain, your anterior westfall nucleus. Can someone tell me who's taking neurodiagnosis? Just this afternoon? None of you taking neuro? And none? You guys are so much older in my brain. Okay, can someone tell me who has taken neurodiagnosis? Right, is that anterior westfall nucleus test?
Don't age shame me.
You're older than me. I can't age shame you.
That's what it means to
I'm actually quarter upping you. So you're welcome.
Well, don't do that.
Someone who's taking neurodiagnosis, can you tell me what that neurodiagnosis is?
Is it the integrating center for oculomotor?
But what specifically? Yeah, so pupillary light reflex, constriction of the pupil, and accommodation. So we'll get to something called convergence spasm or convergence insufficiency, which you can link to your anterior westfall nucleus and your midbrain.
So what was the answer?
Accommodation of the pupillary light reflex. So constriction of your pupil and when your eyes accommodate, which means they converge. And then you have your red nuclei, which modulates movement, specifically in your limbs. So like if I'm going to go grab something, reaching movement. Red, reaching, R's. That's how my brain works. Not sure if that's how your guys' brain works. That's what that does. Your substantia nigra, it has one of the highest amounts of dopamine in your body. I like to think of it as substantia nigra dopamine. If anyone asks you, where's a bunch of dopamine? Substantia nigra. It's really important when it comes to those neurodegenerative diseases that we're talking about, specifically Parkinson's, which I'll get into in a minute. Okay, how to test the midbrain. So you can look at arm swing. When we talk about the red nucleus, it does do reaching wise, pupils are really important. So when your patients one day walk in, I know you're gonna look in the eye, but really look in the eye. Really take a deep look. And be like, are your pupils really, really super constricted, and are you on drugs? Or are they really, really dilated? Or are they the same? Or are they different? So look at those because it can tell you a lot about your patient within a matter of seconds. Vertical eye tracking. So when we do vertical eye tracking, that is a really sympathetic move. So there's some people that you don't want to do this with. So people that are really sympathetic, you want to do those horizontal eye movements because those are more linked with parasympathetic activity more than vertical, which is sympathetic. And then you have ptosis. Can someone tell me what ptosis is? Good job. Ptosis in here. It's drooping of your eyelid, which is innervated by what cranial nerve? Subtract 4.
The third.
Yeah, the third. So it's your levator palpebra, which is innervated by. Yeah, I didn't look at you. We didn't have that. You were right. But it's your levator palpebra, which is innervated by cranial nerve 3, which is body motor. So if you don't have, if that innervation starts to decrease, your midbrain activity starts to decrease, your patient can come in with a little bit of droopy eye. And then the convergence insufficiency, which is what we're talking about. So either they, those aren't the words I want to say. When you converge, it should come in, the way I've heard it described is, it's like 2 paintbrushes that come in and they should come in simultaneously and smoothly. And can they converge is the first thing you should ask. Can they converge and how are they converging? Is it smooth? Is it choppy? There's one lag behind. Yeah, okay. Can someone tell me, so everything activates the midbrain except for what?
That's the question.
So everything activates, every stimulus in the world activates the midbrain except for what? What is sound?
Taste.
What caligula?
Oh,
Meditation. So people with high anxiety or of like what we say midbrain wind up have to do meditation. It's the only thing that they can really, really do that won't just immediately fire into your mind. Okay, before we do that, so we keep talking about midbrain wind up. I have this fun little activity. Can someone be my patient?
Oh, yeah.
So why so brave? Okay, so anyone can do this? Do you all have a deck of cards somewhere or a phone friend that has a deck of cards?
Star Wars cards?
Okay, I'm going to take chances, yes. No, I'm so bad at magic. Ask my friend. No. Okay, so for people with midbrain wind up, we'll get to the basal ganglia in a second. Actually, I'm going to do that first, so never mind. Just down.
Sit down?
No. It's like, I'm going to talk about the basal ganglia and down.
Big
signal. Just keep your toes, you know? Okay, so basal ganglia is really, really, really important in motor control. We're going to go through a pathway in a second. I know we talk about loops all the time, but there's a basal ganglia loop. It matches with your loop that you already know. There's 1 gajillion loops in the brain, so this is just a second one that you guys can know. So your emotion, motivation, and cognition for movement comes from your basal ganglia. Because it has a substantial nigra, which has a lot of dopamine. Dopamine. It has to do with motor learning, executive function, behaviors, emotion, and motivation. So there's this phrase that some people say, not a lot of people say, I'll say a lot, I'm confident in that answer. But you'll have people that come into your office that are mesolimbic, meaning that their midbrain is really high firing, and because it has such tight connections with the basal ganglia and your emotions, you get really limbic in your responses. So there's some people that will do an activity, and if they don't do it correctly, they'll be like, oh, I'm the worst, I'm so bad. Or the people that like hit themselves and they're just like, I'm an idiot, I can't do this.
Just say my name, I want you.
You out yourself, brother. I didn't say anything. But midbrain windup and mesolimbic a lot of the times go hand in hand with each other. And I was telling Chris this earlier, when you're testing patients, especially if you know that they're really limbically wired, be careful when you're testing them treating and diagnosing patients. Okay, structures within. You have your striatum, which is your caudate and your lentiform. This will make way more sense. It goes in a chart. I don't know if you guys are not chart people. It'll go in a pathway, and I don't like words. I'm a chart word girl. Then has your subthalamic nucleus, and your substantia nigra, and your globus pallidus interna and externa. So, you have your indirect pathway. I want to do, which one do you guys want to do first? This is just the basal ganglia pathway. This is with the loop you guys already know. Which one?
Loop it, you already loop it.
That
The right.
one.
The one you're in front of.
This one?
Yeah.
Okay, great. Okay, so you have cerebellum, mesophalamo, cortico, which you already know that. But your cortex fires into your striatum. This guy. Striatum, tomato. Which your striatum in nature is inhibitory. It's like it is inhibitory unless something is going desperately wrong. Then it's just going to inhibit less. But it always inhibits. Your striatum fires to your globus pallidus interna and externa. So right now we're talking about the gas, which is how movement happens. But if I'm just all gas, I'm going to go. If I'm just all gas, I'm going to be like here. Because I have no brakes. It's really hard. But I have no brakes. So I don't have anything to stop me from like, okay, I got there, but I'm just going to keep going because I have nothing to stop me. So when it fires from your striatum, it goes to your globus pallidus interna, back to your thalamus, back to your cortex. So it's a continuous loop. This is always firing. At the same time, this loop is always firing, which is your brakes. It's a pulley system. You have too much gas, you have too much brakes. You have too much gas, you have too much brakes. So you're just going to go back and forth between the two. Unless you have a neurodegenerative disease, then you have too much of one or the other. So in your brakes, you're firing from your cortex. So here, you're going to go through the loop you guys already know. Cortex, striatum, then you're going to go to your pallidus, which is that externa for your brakes, externa brakes. And then you're going to go through subthalamic nucleus, and then into your interna. So you're always, at the end point, you're always going to end here and go back to the thalamus. This might not make sense right now. This pathway is really hard and it took me like 2 years to get. So if you don't get it right now,
I don't see how to relate at all.
This is just this part right here, but you guys know this part. But this part's within that. Because your meso has this within.
So all of that's occurring. No, it's not. Within
If you're firing your cortex, you're firing this.
The basal ganglia is constantly firing.
Firing, always. You're
Endlessly.
constantly moving. You know?
The reefer.
Okay, do you guys see how palido is globus pallidus, interna and externa? Right, so it's like structurally it looks different.
And sorry, Luigi in the subthalamic nucleus. Because it's the subthalamic nucleus of Luigi.
I mean, yeah, so like that is the same as that, and that is the same as that.
Yeah.
Yeah, we're going to put all the
Those
others.
connections.
Here we go. So this is simultaneously firing. So when you try to grab something, so that I can grab it and stop here, my gas has to go so I can reach for it, but it has to stop at the cup. So I can't go right, so I'm not getting the arm carpet. Probably use a wash, but I have to be able to brake. Otherwise, I'm going to get these jerky movements because my gas pathway, which is this pathway, is overfiring, and I'm getting no activation of my brakes. So you guys have any questions?
Is that a link?
So jerkiness could also not only be cerebellar issues, but like a basal ganglia loop issue.
What do you mean by
The gas and the brakes not simultaneously acting at the same time.
yeah? So that yep.
So basal ganglia, think spastic. Cerebellar, think hypotonic.
Dr. Ellis had also explained it to me about like, just always think cerebellar, think like more like drunken gait, right? So you're like floppy, uncoordinated. Like they have an attention tremor, but it's more like uncoordinated base, right? Like basal ganglion is like more pill rolling tremor, right? So it's like, yeah, okay.
Okay, so we're gonna go back to, yeah. Okay, so you can have, for basal ganglia lesions, the two most common ones that at least I've seen are Parkinson's and Huntington's. So I just learned that Huntington's, I don't know what you guys know about Huntington's. You guys know what?
Decent.
Okay, well, fun fact, the substantia nigra just like, no. What did I say, Blanche?
Huh?
What did I say in Huntington's? What just literally goes away?
The basal ganglia.
Yeah, but there's a specific part. Anyway, the basal ganglia just
Oh, the striatum.
Striatum. The striatum just literally degenerates until it's nothing. So essentially with Huntington's, you just get these jerky movements because you have, your striatum is just decreasing and decreasing, but it's decreasing in your indirect pathway. So you get just gas. So you get all these jerky movements all the time because your gas is overfiring. So you get just a bunch of jerky movements. Whereas Parkinson's, you have, something about this. You have too much, it's a gas issue. So you're not getting enough gas. You have an overfiring of your brakes. Because in Parkinson's, how deep do you guys want me to go into this? Because I could go.
Let's go.
Okay, great. So I have a Parkinson's patient right now. He has a slew of issues, like had 6 rounds of chemo, 2 car accidents, he had a bladderectomy, he had 2 eye surgeries in his right eye. So like, he came in and I was like, oh, I thought I knew things. Let me take your history. But he has Parkinson's pretty bad. He's 70 years old. And his problem is that everything is slow. Like, because his brakes are overfiring, it's slow. So Parkinson's is neurodegenerative dopaminergic cell death. Oh, that's a lot of words. So what's the highest, where is the highest amount of dopamine? Brains. Gorgeous, you are brilliant. So if I have a decrease of dopamine, so technically you guys have different, this is gonna go really biochemy, and I'm not even a biochem person, but it'll make sense in a second. So you have different dopamine for this versus this, and the dopamine here starts to degenerate. Those are the cells it targets. We don't know why, it just happens. So then you get an overfire, technically it looks like an overfiring of your brakes, because this pathway breaks down, this pathway doesn't. So it overfires, then you're really slow, your like, gait is like, oh no, I don't know where I'm going, and like, I did tandem gait with him, tried tandem gait, and he's right next to a wall. Cause like, I could catch him, but like, I also don't want to die, so like, he'll do this, and he'll just like go into the wall, and I'm like, oh, it's really hard. But like, let's go into the wall. Or just hold the wall, I'm like, okay, well, I don't know if that's really doing anything for you, but you know what, get out there. But, so you have these D1 dopamine receptor versus D2. That's the difference. You guys want articles that have 100,000. But yeah, that's what happens with basal ganglia. Either you have these really, really jerky movements, or you have these really, really slow movements because your brakes are on. So jerky, what path are gas? And then if you're really slow, which is bradykinetic, you're thinking overfiring of your brakes. Any questions? This one a lot.
Would any of this have a link towards Tourette's or somebody that has a tic?
Yes. I'm going to let Bonacci talk about that because he did a lecture on Tourette's.
So for Tourette's, again, they're not really sure, but Tourette's is, they think, is a little more sensory. So it has to do with that I have this itch on my arm that is so insatiable that I have to itch it. And so it's more of like a product, like I have to do it, but then it reinforces your dopamine system and your reward system, which would be a little more midbrain basal ganglia, so it would tie in. So it's like every time I do it, it's like it almost becomes autonomic because that loop is firing. And so you just be sitting in class and go, because that loop, and it's like tickling that.
What about verbal Tourette's?
Same, because basal ganglia is cognition as well, so it's almost like there's like this thing stuck in the throat. Like it's like they have to, it's sensory. That make sense?
Okay, I'm gonna show you a fun little nerd game after you ask your question. Yes.
Is Huntington's often mistaken for Parkinson's or vice versa?
I can't answer that with any sort of certainty, but I want to say, like, if I had to take an educated guess, I would say no, because they present differently. Like, Huntington's is really spastic, where Parkinson's is very slow. Everything is slow. Everything they do is slow. It's just like my patient is so slow. I love him. He's great. He's incredible. Yes.
You also get Huntington's appearing a lot earlier on than you would expect.
Huntington's is like 30 to 40, whereas Parkinson's is like maybe early as 65.
A lot of times with Huntington's, there's also, because it's so genetically driven, there will be a family history. There's often a family history of it.
Yeah, so I want to say no, based off of all of the info. Okay, Monday, Kelly. Okay, so this is something I see a lot. It's funnel, basal ganglia, all the midbrain things. You're just gonna face it. I know, it's okay. I'm just so patients will typically, you do this a bunch of different ways. It's really just using your brain to think of something that is a therapy, but also at least semi-fun for the patient. So with your right hand, I want you to hit the black cards. With the left hand, what did I just say? Right hand, black cards. Right hand, black, left hand, red. Okay, ready? Oh!
I would be
I don't have a Dave Buster's.
So you get patients that it's really hard for them to do this. You could also do it so like if I said, oh, come back. Why trying to leave me? You could also do it so that you're like, okay, with every face card or with every even number, tell me an animal. And we're gonna go in the alphabet. So like she'll do A, I'll do B, she'll do C, so we're gonna do that. Ready?
Wait, what?
So for every face card you get, tell me an animal.
What's a face card?
It's got a
Jack
face.
and King.
I don't play cards very much. Okay. And I have to say it starts with that letter?
Yeah, so you're gonna start with A.
Oh,
Tell me an animal. And you still have to do the, what are the cards?
I thought so.
black cards, protons.
Good.
Alligator.
Oh! Buffalo.
Oh, God, it's your turn.
Yeah.
Crocodile.
You're not supposed to slap it.
So she is slapping the cards with the
The face card. Are you
designated.
not supposed to slap the face
No,
card?
you are, but you're also going to tell me an animal.
Okay.
So then at the end, we're going to go back and she's going to tell me all the animals we said.
Would you tell them?
Yeah, so it's really hard. Like this game is
That's
really
not
hard for
funny.
people to. No, it's not.
How is it
But it's,
funny?
think about it. She has to think about which hand she's hitting, the color she's hitting, and has to think of an animal. So this is cerebellum, frontal lobe, basal ganglia. Like, can I? So people with like OCD or Tourette's, like that. I don't know how to for Tourette's actually. But like OCD, you have to fire that pathway and be like, I don't have to turn the knob 18 times before I can leave my house. So this could be good for them. I don't actually know that. Actually, I used to have it, and I did this as a therapy with my doctor. So I do know that it works. And I know, well, I do have to lock my car 3 times before I leave, otherwise I think someone's going to break in. That's what that would be. Anyway.
How good are you at that game?
I'm not very good. This game's really hard. So like maybe start with just doing right hand versus left hand. Or like I didn't immediately go right hand red because that makes sense in my brain. Right hand red, left hand left. Just because of red and right. But you like the more your patient gets better, make this harder. So like do odd numbers that are black, left hand. Even numbers that are red, about their face card, tell me a soccer player. Like, you can make it hard.
Can you, like, for every odd number, you don't hit the card?
Yeah, so like there's I don't know if you guys have ever seen a D2 board. I can show you what that looks like. It's called a D2 light board. There's this thing called go no go. It's like a therapy, and it's like you hit all of the red ones, but you don't hit the green ones, and it's just like let me pull it up. This is what this looks like, and you can like on this little screen, you can do math. So like you could have math going, and then you can say, okay, only hit the red ones, and red and green ones will pop up. So they have to have the motor control be like, oh, that's not it. Or like I have to hit that one, but you also have to do math, or you have to say the word, and then you have to remember what the words were that you said at the end. So like, there's a bunch of different things you can do. But if you don't want to spend $14,000, you could just have a debit card. But like $14,000, everyone's got like pocket change.
I said Dave & Buster's because I literally just went to Dave & Buster's and there was a game exactly like this.
Yeah.
It was awesome.
It is really.
I haven't been since I was like 7, so I can't.
Where did you
Yeah.
go?
So, you necessarily have to say what the games in order for you to actually see movements.
Say that again?
You don't
No.
have to do that.
So like you're just firing that pathway. And granted, like if they get really Mesolympic, like if I did this with Zach, she'd be like, fuck, oh,
That's
and like
true.
it might not be good for him to do this because it's firing it, but it's negative plasticity because he's over firing his midbrain. So you kind of gotta walk that line of like, is this good for my patient? Always ask that. You can do a pre and post check of
So
like,
competitive.
yeah, and like the old patients are like, I can't lose. It's like you're gonna lose.
Yeah.
Like these are designed to be really hard because you're stressing something that's already either not working correctly or overworking in the wrong way.
Do you think that, like obviously speed is important in what we do. Do you think that slowing that for mesolimbic patients, slowing it down and being like, right now, speed doesn't matter, just get them right, would actually be more of like a positive reinforcement to where you can actually do this therapy on mesolimbic people that get frustrated really easily because they keep screwing up.
Yeah.
It's because they're going too fast.
So like think of interactive metronome. So like I don't know if you guys know what interactive metronome is. You basically either have a sensor, you can have it anywhere, you can have it unilaterally, and it's just like a little, kind of looks like if you press it, something's going to explode, but it's just like it wraps with Velcro on your hand, you can do it on your feet, and then there's a metronome going. And for patients like that, you have it be really slow, because they're hardwired to get, so then you're going to have it go like this. And they're just gonna, like, they're gonna be wrong almost every time. Until they're like, their brain fires that pathway, be like, okay, don't have to go right now. And go like this. So it's just like how you want